So welcome everyone to the TCT virtual training course. The theme for today is mechanical thrombectomy using the angiojet device. I have two very distinguished speakers from Korea, Dr. Seung-jae Byun and Dr. Chamin An. Dr. Byun is a vascular surgeon with lots of experience from his days at Wongang University, and now he runs his own private clinic. And we also have Dr. An, who is an interventional cardiologist at Severance University Hospital, also with a lot of experience with the angiojet device. I would first like to ask Dr. An to present his slides, and we will have a very brief discussion after his presentation. Dr. An, thank you.
Thank you, Chairman. I'm Dr. An from Severance Cardiovascular Hospital, Yonsei University. My case was acute rim ischemia managed by the angiojet thrombectomy devices. In femoral popliteal artery, there are many kinds of lesion and characteristic of some the occluded lesion. The classification from chronic total occlusion and thrombotic lesion. So in angiojet devices, we attack the thrombotic lesion. It's composed of the ultrasonic and the pump set and catheter. And we have many kinds of a catheter available for many lesions. And main mechanisms of angiojet was isovolumetric, some aspiration of some clot at various lesions. Its jet was some high speed jet backward travel was make a negative pressure inside of some catheter, and it can make some isovolumetric aspiration. And two kind of the mode was available. And first was thrombectomy, was direct thrombus aspiration, and another kind of mode was a power pulse mode. It's some delivery of some thrombolytic agent at the thrombotic lesion, and the lysis of the thrombus was we uses a two kind of mode for some remove of a thrombotic lesion. And usual doses in Korea, the TPA was available for some power pulse mode, usually 10 to 20 milligram in 100 normal saline. And indwelling time was at least 30 minutes because of a half time of the some thrombolytic agent, and the thrombus was some sufficiently lysis by the thrombolytic agent. And available catheter was some Gelant DVT, was a French usual for some deep vein thrombosis. And then in artery lesion, so we use Omni for a long shaft 6 French, and Omni Proxy was a short size of 6 French. It's usually for some arterial thrombotic lesion. Let me introduce my cases. Case 1 was 75 male, and 1 hour ago, some onset of light low leg pain. It's grade motor was grade 2, and sensor was intact. He has a history of persistent atrial fibrillation. CT shows it's acute some occlusion of from the common femoral to superficial femoral artery of mid to distal portion. Angiography shows the left external iliac had some stenosis, and the right side was the flow was very limited from the common femoral artery. And the selective angiogram shows it's some thrombotic occlusion of common femoral artery. And initially, we wire was very smoothly penetrated without any resistance. So it's we suspicious it's a very fresh thrombus lesion. And distal angiogram shows good, no significant stenosis. So we at that time we used the urocinases, and the urokinase was scattered in the lesion for some power pulse mode, for some proximal to mid SFA, and we wait for 30 minutes. And during the waiting, I tested the angiogram. There are slightly flow, some improvement during the procedure. And then we suctions, thrombus suction with angiojet devices from proximal to distal with the use of Solent proxy. And after the suction, the fresh thrombus was completely some remover without any some embolization of distal portion. So actually, it's initially it's indicated for some Fogarty embolectomy, but at the time there are some problem for some surgical some approach, so we started this procedure. And you can see that the proximal common femoral and then deep femoral had some residual thrombocyte there, and we had another suction to common femoral area, and there are little embolizations of some thrombus to the deep femoral artery. So we rewired the deep femoral, and then another suctions for deep femoral, and then finally the flow was much improved, and the symptom was improved, and motor was restored from the normal ranges. Second case was 10 hours of both leg pain. He has already had a many history of peripheral angioplasty, and also had a diagnosis as a Buerger's disease. At that time, we checked previously the ABI was 0.8 to 0.9, but that time the left side also decreased and the right side was 0.2. And skin perfusion pressure was much decreased at the right side. And you can see that the fem-to-fem graft and fem-to-pop graft already occluded, and left side also had some had the stenosis from the some common femoral to the superficial femoral. There are there are already some occluded the light common iliac artery, and then iliac graft was already occluded the previous years. So only approach some site can be some the left popliteal artery, and patient was a prone position and popliteal approach, and the wire was a very smoothly transferred to the common femoral, superficial femoral, and the fem-to-fem bypass, and then the wire was down to the contralateral side. And then we changes the 6 French and NCLCs, and the angiogram shows it's a very slow flow, and the fem-to-pop also had some very flow was very limited. So we urokinase injection at the site of the graft, and after the 30 minutes, and we performed the angiojet devices at there. And finally, the flow was much improved to fem-to-fem and fem-to-pop. And there are some small residual thrombus at the fem-to-fem bypass. So we performed another some angiojet procedure. And then finally, the flow was much improved, but the residual stenosis was treated by the balloon angioplasty. It's another thrombectomy. And finally, the flow was improved, and CT scan shows much improved for some the angio by angiojet, and then the last cases was 6 hours of left leg pain. He had already peripheral angioplasty at the other hospital. So angiogram shows its previous stent was totally occluded, and the wire was very smoothly past the lesion, and popliteal stent was also performed at the other hospital, and the wire was very smoothly past the stent. So I think it's mainly a thrombotic lesion. So we performed some power pulse mode of urokinase, and then performed the angiojet devices. And there are all remove the thrombus. There are residual lesion of femoral popliteal lesion. So we perform the angiojet first, and then the balloon and DCB at the femoral popliteal lesion. And finally, flow was very much improved. And okay, it's a final flow of after full angiojet and angioplasty. But some cases, it's a chronic thrombus. So after it, you can see that the thrombus, and then there are the organized thrombus material. So after the pulse mode was performed, uh, but there are still residual some organized thrombus. So I think always possible for some old thrombotic lesion, but in fresh lesion and new onset lesion was a very much some improved after the angiogen devices. It's my cases. Thank you for kind attention.
Thank you very much, Dr. An. I think I would like to ask you one question about when you perform a thrombectomy, how strict are you in keeping with the thrombectomy time? Because Boston Scientific recommend a certain limit in the time.
Yeah. So usually you know about the total across lesion, the total available time was 480 seconds. And then there are some flow was already open. There are less than 240 a second was available for some the thrombectomy devices.
Thank you very much, Dr. Han. So I would like to now share my presentation. So I think we're very limited for time, so I will make my presentation as short as possible so that Dr. Bjorn can have enough time to present his own. I'd like to show you just two cases, and I will skip these slides because we know how it works. Like Dr. An, I will also present a couple of cases on acute limb ischemia, and these are more of the less likely cases that we come across. And one is for upper limb acute limb ischemia. This patient had a history of stroke, and the neurointervention radiologist performed a procedure for stroke intervention, and the patient eventually got right arm discoloration and pain, and we found that the patient had a thrombus in the right arm. So you can see one in the proximal brachial artery. And we went in with the normal wire, and the guide wire would pass through very easily, so that would suggest this is acute thrombus. And with the conventional techniques that we have very, for example, if we use aspiration catheters, most aspiration catheters are 100 centimeters in length, and all the devices that we have, when we come from the femoral axis, are very short to treat thrombus in the arms. So I think one of the advantages of the angiojet device is that we have 120 centimeters of length, so we can reach from the common femoral artery all the way down to the antecubital region. So in this case, we inserted a 100 centimeter 6 French shuttle sheath into the proximal brachial artery. And then we did a couple of runs with the angiojet device. We did a total of 2 passes. over 260 seconds, but it was a very long segment all the way down to the antecubital level. And after we did a couple of runs, so that's going all the way down to this level. So you can see how far the device can reach from the femoral axis. This was the intermediate result after 2 passes of the androjet device. This was more distal. You can see the radial artery is still occluded. So the ulnar artery is still occluded. And on the distal hand, you can see some embolization in the hand. So in this case, we decided to do a low-dose thrombolysis through the sheath. And this was the final result. So now you can see just 60,000 units of urokinase infused. So this is relatively low dose compared to the conventional catheter-directed thrombolysis regimens. And you can see all the outflow has opened after this treatment. The second case is a patient with acute limb ischemia. You can see the patient has bilateral iliac artery and femoral artery occlusion all the way down to both popliteal arteries. And you can see in the left atrium, the patient has a large thrombus. So we know the cause of bilateral aortoiliac occlusion is due to this thrombus. So in this case, it's difficult to decide an axis because both femoral arteries had thrombus inside them. So we could do bilateral puncture, but in this case, we decided to do an axillary axis. And this was possible because the androjet device is only 6 French. So we did a pre-close technique in the axillary artery. And then we put a sheath and did an angiogram. And you can see that the patient has both iliac artery occlusion. And in this case, we did a wire passage all the way from the upper extremity, and you can see the wire is passing down without any resistance. Again, it's showing us that there is a very soft thrombus. And again, with 120 centimeters of length for the androjet catheter, you can reach all the way down to the popliteal. And this patient was a 170 centimeter patient. So you could get from the axillary artery all the way down to popliteal. And we did the same for the other side, for the other leg, through just one axis. But this is the other side, going all the way down to the popliteal. And after about 65 minutes, so about 1 hour, I could do recanalization of both iliofemoral arteries through just one axis. And you can see both femoral arteries are now open. So total procedure time, 65 minutes. Thrombectomy time was 8 minutes. Thoracoscopy time was only 33 minutes. So I think this is also one of the advantages of the androjet device is that you have 120 centimeters of whole length and a very small French compared to the other thrombectomy devices. I just showed you a couple of cases where I did thrombectomy alone and then thrombolysis, low-dose thrombolysis afterwards. But also you can use thrombolysis, adjunctive thrombolysis, or the power pulse mode. So the different combinations that you can use. And also, as you can see, in these patients, we just did a single session. So if you look at the Pearl registry, there are 86% of the patients had less than 2 sessions. So this is also one of the advantages of the androjet device. Okay, thank you for your attention.
Dr. Kim, I have one question.
Yes.
Your first case and maybe embolus and sometimes embolus material is
Yes.
very hard. Therefore, thrombolysis effect is very poor. Therefore, many surgeons the embolic disease is met at that time. Surgical thrombectomy is first recommended. What do you think of that?
So I completely agree with you. We've done many cases where we had, at the final, we got out the fresh thrombus with the androjet. And as you say, you have a fragment of hard thrombus from the heart or somewhere else that is left over in the distal. We had a couple of cases where we had the surgeon had to eventually cut down, as you say. We also had a couple of cases where we did a brachial puncture to get it out. And another case, we used off-label use of solitaire device from the neuro intervention. Different techniques, but I completely agree with you that we do have some cases where we have fragments left over. Yes.
Okay.
Okay.
Yeah, time presentation.
Yep. So due to time limitation, we have 10 minutes left for you, Dr. Ven. So
thank you.
I'll stop sharing. Okay.
Good day, Chairman and gentlemen. I'm Seung Jae-byun. I work with Changhyun Seung Vascular Surgical Clinic. Today I will share my experience of mechanical thrombectomy using angiojet for the treatment of DVT at Wongang University Hospital. My favorite mechanical thrombectomy devices are large bore size catheter or angiojet. Large bore size catheter is cheap and effective for acute and subacute thrombus. But this advantage is frequently T-cell embolization and sometimes develop vessel injury and remain thrombus. But angiojet catheter is expensive and not effective for subacute thrombus, but is effective in acute thrombus and less distal embolization. This is the A French shuttle catheter, and shuttle catheter reach to the thrombus, and then shuttle catheter move to the floor for aspiration on the negative phase of syringe. And this slide shows a lot of aspirated thrombus into syringe. After aspiration, almost thrombus were removed, but common iliac vein was not visible, and also vein wall showed remnant thrombus. After guide wire pass and venogram show severe iliac vein compression with collateral vein.
죄송합니다.
And stenotic lesion treated by PTA and stenting. Final venogram show good recanalization and disappeared the collateral vein. If shuttle catheter is not effective, 11 French arrow catheter was recommended. At first, as shown in the figure, cut off the head of the 11 French arrow sheath and connect to the 50 cc syringe, and then try to do aspiration in the same method. And this slide shows aspirated organized white thrombus. This is the angiojet and console and catheter. And DVT treatment time using catheter is Gelant. At first, my first using time is 2018. That time is Korea is available. Angiojet have two modes, different technique. One is power pulse delivery, one is aspiration thrombectomy. And treatment strategy using angiojet is variable. But my usual strategy in past, that means is available neurokinase, overnight CDT, and then angiojet PMT, and remained region PTA stenting is very effective. But nowadays, UK is not available. Therefore, power force mode by angiojet and aspiration thrombectomy by angiojet, and some remained region is treated large bore size catheter and PTA stenting. If some remained region is I'm treated short time thrombolysis using PPA. Free case, 6-7 men left with swelling. Symptom duration is just 1 day. Previous CT showed the IBC, iliac, common femoral, foraminal is total occlusion. At first, IBC filter insertion, and foraminal puncture and venogram show iliac and common femoral is total occlusion. And then power force delivery technique using and usually TPA 10 milligram, and 200 is saline. And injection after them, and 10 and 15 minutes is waiting, and thrombectomy using angiojet. But I think that the increasing power pulse delivery techniques time will have a very effect. This is just my idea. Company recommended 100 saline mixed TPA, but I'm the 200 saline mixed. Therefore, increasing pulse delivery techniques time is more effective. After that, after angiojet thrombectomy, thrombus reserve both visible stenotic common iliac lesion and treated stenting. And final venogram is very good recanalization. Recently published my paper in safety and efficacy of aspiration thrombectomy and pharmacomechanical thrombectomy after CDT. At the time, is available urocanase. And to evaluate the safety and efficacy of different patients in additional aspiration thrombectomy or angiojet PMT after CDT treatment. And retrograde study and 40 patients, 20 patients is CDT and then 80, 20 patients is CDT and angiojet using pharmacomechanical thrombectomy. And thrombus clearance is grade 3, more than 75% thrombus clearance that define the success outcome. And angiojet group is included more severe thrombus lesion, but angiojet group is significant decrease in thrombolytic therapy duration and urocanase dose are noted. And successful thrombus clearance was achieved in both group and 95%, and major complication was not noted. Angiojet group showed 85% present gross hemoglobinuria, but it returned to normal within a 24-hour after procedure. And adverse events such as renal dysfunction and major bleeding was not reported. This slide is very interesting. And this major thrombi, many thrombi was observed in retrieved inferior vena cava filter. And residual filter thrombi more than 10 millimeter were found, 6 filter in the CDT-80 group. But CDT-PMT angiojet treated group, just 1 filter is visible more than 10 millimeter. In conclusion, maybe CDT plus PMT using angiojet an effective and safety treatment modality for DVT patient, acute DVT patient when compared to CDT plus AT, and angiojet group similar treatment success rate, and reduce thrombolytic therapy duration, and reduce total dose urocanase. Thank you for your attention.
Thank you, Dr. Byung. May I ask a question about your experience with hemoglobinuria? Because there are some papers contradicting results. Some papers say that benign hemoglobinuria is not benign. Some people say it does actually lead to acute renal failure and it's underreported. So what is your opinion on that aspect?
Gross hemoglobinuria is all case, maybe 80–90% is all cases observation, but there is major problem is renal failure. Creatinine is clearance is 0.1 is increasing, or hemoglobin level is 2 point is decreases some major gross hemoglobinuria, but my case is not. Therefore, this is a very normal finding after angiojet aspiration thrombectomy. Therefore, I recommended the short time angiojet is recommended.
Right. Thank you for your valuable experience. So we have just 1 minute left. So I hate to rush things, but I would like to close this section. First of all, I would like to thank you again to Dr. Byun and Dr. An for sharing your valuable experience. And I would also like to thank Boston Scientific for arranging this exciting event. Okay, thank you very much. Bye-bye.
Thank you.
Bye.